Good morning for those of you who are in Europe, and hello to everybody else. A warm welcome to this eMHIC webinar. My name is Fiona Costello, for those of you who don't know me, and it's my pleasure to be your host for today's chat, during which we'll be talking about better digital tools for mental health. This webinar will explore the use of technology and its potential to reach underserved populations and complement traditional treatment methods. Despite its potential, technology faces challenges in international adaptation, uptake, and adherence, involving various stakeholders, especially end users in every stage of technology development, is crucial to adapting these digital solutions to the needs of different national contexts. The SUPER project aimed to enhance the level of user involvement in developing and adapting digital mental health solutions on an international scale. To do so, the project team set up guidelines and tested them during tandem pilots, adapting local digital mental health solutions for adoption in another country, in this case in Denmark and the Netherlands. Lessons learned from these pilots further formed the final guidelines. During this webinar, the SUPER project team will discuss the results from the tandem pilots and the resulting guidelines. And we're really thrilled because we know how much it influences how we think about digital health, how we think about digital mental health, and making sure that we're meeting the needs of those with lived and living experience. You will hear from each of our speakers soon, but first, and as always, I have a few quick points to mention. Please feel free to share your current location or area of interest. To do so, you can click on the three dots next to your name tag, choose Edit, and add your country or area. This allows you to connect with others who share similar interests. If you have any questions for the panelists during the webinar, please feel free to post them in the chat box. During the Q&A session, I will do my best to include as many of them as possible in our discussion. Feel free to post questions both during the presentations and after as we start the panel discussion. And finally, today's webinar is being recorded and the eMHIC team will soon share the recording in the Knowledge Bank. So with all of that said, it now gives me great pleasure to introduce our first speaker, who you may recognise from a few webinars ago, Yvette Roque. Yvette Roque has been a psychiatrist at GGZ Centraal, the fourth largest psychiatric hospital in the Netherlands since 2001. An innovator and researcher, she earned her PhD in 2013, focusing on prolactin-related side effects of antipsychotics in children with autism spectrum disorder. Post-PhD, Yvette developed SAM, Stress Autism Mate, an e-mental health app for ASD self-management. She won the Health Valley Bridge Prize and Tenzinger Healthcare Smart Innovation Award in 2021, and SAM earned a Bronze Award from VGZ in 2022. Her team also created SAM Junior for young people with ASD and One eStat for those on mental health care waiting lists. These apps, co-created with lived experience individuals, are scientifically validated, secure, and available in 7 languages. Yvette, we're thrilled to welcome you back.
Thank you, Fiona, for such a nice introduction. I'm here as a lead project for the SUPER project. It stands for Successful User Participation Examples and Recommendations in Digital Mental Health. And why we did this project is because 25% of all people have a mental health illness during their life. So either we get one ourselves or a loved one we know has mental health issues. And there are a lot of waiting times and a lot of problems to be bridged, like problems in the workforce. And there are a lot of best practices in one country that can thrive in another country, but we lack the tools to do that successfully. So this is why the SUPER project decided to make a guideline, a practical guideline, like a kind of an IKEA guideline, how to culture adapt best practices from one country to another. And in order to do so, we want to co-create with end users. And also in this project, we co-created with our end users, our stakeholders, our takers. So we involved 66 small, medium enterprises, NGOs, patient federations, health institute, to work with us, to know what they wanted in the guideline, to give us feedback, and to really co-create this together. So it's my pleasure to have my team members introduce all the different steps we took, and after that have the panel discussion. So Fiona, back to you.
Thank you, Yvette. Sylvie, we're now going to be joined by Sylvie Bennett, a digital mental health researcher and the People and Wellbeing Research Group, Research Line Psychology and Technology. Her areas of expertise are immersive technology and artificial intelligence in mental health care. She currently works on the AI Cares project and the European Interreg project SUPER, which is the subject of today's discussion. With the knowledge and expertise gained from these projects, Sylvie advises the professional field on the implementation of immersive technology in their organisation. Sylvie, it's our sincere pleasure to be joined by you today. Please welcome Sylvie for us. Hi, Sylvie.
Hi, everyone. Thank you, Fiona. I'll share my slides. See whether it's the correct screen. This is the correct one, I think. Okay, so hi, everyone. I hope you can see my slides. So my task here today is to briefly kind of give you a bit of background on the why of the super project and the why of user participation. So my brief talk is based on the opinion paper we wrote, and at the end of the slides, I show you the reference so you can read a bit more if you're interested. So I'm going to briefly walk you through some approaches for user participation in digital mental health, its potential, and the need for guidelines. Why do we have the super project and why user participation? So to provide you a bit of background, digital mental health interventions can be cost-effective, can be effective, especially for anxiety disorders, depression, mood disorders. We know that these kinds of interventions are effective and they work. What we actually also see in research and what we see in practice is that implementation is very challenging, mainly because adaptation from applications of one context to another, also uptake is often very difficult. And even when there is good uptake, it's difficult to keep people engaged and to have this adherence running in a good way and keeping it up high. So these things are actually quite difficult. And from our experience in this project and the experience of our partners in Denmark and in the Netherlands, they have experience with how user participation or user involvement can actually be beneficial to at least help with some of these aspects, so with adherence, with uptake. So we see user participation as a part of the solution. So there are different approaches to user involvement or user participation. And in essence, it actually just means that you want to involve the people or your intended users or different stakeholders in this development process, design process. So in essence, it's just that, getting people involved. Now, who are these stakeholders? Who are these users, these intended users? They can be patients or clients, depending on the terminology you want to use, their family members, their loved one, friends, but also clinicians, mental health organizations, and even developers. In our project, we mainly focused on intended users, but it's definitely interesting to have a broader look at that as well. And there are actually multiple approaches to user participation or user involvement, which actually have different aspects or degrees of control for these users. For example, you have user-centered design, where you actually design applications, or in a context of digital mental health, you can design applications with your users in mind, with the knowledge you have, or asking their opinions, but not necessarily involving them from the start. And this is what you can do in participatory design or co-design, where you actually involve them from the start in assessing the needs, in assessing the challenges, and really getting them involved from the beginning. And then you have user innovation, which is maybe a bit less known or less popular because it's quite difficult to do. And this is actually innovation that starts from your intended users. They have an idea, and this is how everything gets started. So from our perspective, we started with applications that used participatory design, were co-designed. And then for adaptation, we used more of a user-centered design mindset in background. And if you want to do this in practice, there's not one clear method actually on how to do this. You have focus groups, you have surveys, interviews, all these different kinds of methods, and people don't always know how to do this and where to start. So now, what is the potential of user participation? Actually, although I would like to say that we know from research that everything works better when you involve them, from research perspective, we actually know that there's mixed evidence. We know that user participation or co-designing, participatory design helps to limit known barriers. For example, there's evidence on when you engage youngsters, young people, students in applications that you create for them for mental health disorders that are very that happen a lot to them, then this user participation can help them involving and can help them to how shall I put this? To address some really intervention-specific factors like getting acceptability up, getting uptake up, but also person-specific factors, getting the motivation better, understanding the needs better. And this is not only proven in young people, but also in elderly. And then we also know that although we don't know really, or evidence doesn't really support that applications become more effective, we do know that involving users helps to enrich ideas, increase acceptance, improve engagement, which can lead to better adherence, and also to improve cultural sensitivities, which is really important in this international context. And this is how we come to actually a need for guidelines. We know some stuff from research, and we have experience with positive effects of involving end users or involving intended users, but it's not always easy to find how to do this. So this is where we had the idea for the super project as well, that there are existing frameworks, but they're often hard to find, especially for clinicians in practice. Researchers can find them, but we're not always the ones developing the applications. So we need something that can be more easy to find, and we need to be consistent in our terminology. We need to have a comprehensive framework, not just explaining how you could do a survey or how you could do a focus group, but really look at the bigger picture with a bigger framework. And also focusing on international adaptation, not just using an application in your own country if it works well and you want to, as a company, maybe even have more people using it, then how should you go about this? So this is kind of the background of the super project and how we had the idea to do this project. So if you want to know more about this, you can, I'll happily direct you to our opinion paper, where you can read a bit more and have a bit more time to go through all these things and these concepts and the research in background. Thank you.
Thank you so much, Sylvie. I think it would be really helpful if we could include the link to the opinion paper in the chat. I know that that's got me thinking about some questions, so I'm sure it's got the audience thinking as well. We're going to now be joined by our final couple of speakers who will be making up this panel. The first is Søren Lang-Nielsen. I hope I pronounced that properly. Søren is a project manager at the Center for Digital Psychiatry in the region of Southern Denmark, where he works with regional, national, and international projects dedicated to developing, implementing, and evaluating digital mental health solutions. In particular, this includes the use of video consultations and the assessment and use of health apps in a national and regional context, such as mindapps.dk, a platform that assesses and promotes trusted health apps. Søren will be joined by Christian Korte-Carlsen. Christian works as an implementation consultant at the Center for Digital Psychiatry in the region of Southern Denmark. Christian specializes in user engagement and works with it as a central role in designing digital solutions. His expertise primarily revolves around fostering collaboration amongst stakeholders and analyzing their requirements to design optimal services. Christian has been a key participant in working with co-creation in projects such as MindApps, which assess and displays quality assured health apps. So please join me in welcoming Christian and Søren. Thank you both.
Thank you for that presentation, Fiona.
I'll just share our slides. Hang on. Right. So, since you already heard about the project's background and emphasis on user participation, I will emphasize on what we have actually done in the project and our recommendations and lessons learned along with Christian. So, Super has been a small-scale project with one key deliverable, an easy-to-use guideline for planning and facilitating user participation, in particular when adapting digital mental health solutions to new markets. So to ensure its relevance, we pilot tested the guideline by adapting and scaling two digital tools. We also formed an expert group of over 60 individuals from across Europe who helped refine our approach. And finally, we disseminated our findings through events, academic articles, and our recent final conference in Copenhagen. To optimize our guidelines, we tested them in practice by adapting two digital health solutions, respectively the Dutch app Stress Autism Mate, or SAM. SAM has been developed with a high level of user participation by our Dutch partners to help individuals with autism manage their data stress, which can be a significant challenge for this group. Moreover, we included the Danish app Safe, which has also been developed with a high level of user participation in the region of Zealand. The Safe app provides information and guidance on self-harm prevention to individuals who self-harm, their relatives, and clinicians. So during the project, both of these apps were translated, adapted, and user tested within the opposite market to ensure its local relevance. Of course, following our guidelines so we could optimize and refine them further. The overall approach we have used is based on design thinking, which is a user-centered methodology to develop and adapt digital solutions by involving users to better understand and meet their needs and challenges. Accordingly, our guideline follows the 5 iterative steps of design thinking: emphasize, define, ideate, prototype, and testing. To begin with, we focused on emphasize, which is crucial for the remaining steps. Doing so, we wanted to better understand the intended users in both Denmark and the Netherlands. We did so by conducting thorough desk research on the current solutions and talking with clinicians and users to challenge our own assumptions. Through this, we confirmed the need for both apps. For example, Danish clinicians confirmed a gap in stress management tools for individuals with autism, supporting the app's relevance in a Danish context. We also learned the hard way that recruiting vulnerable populations takes time if you want direct access and engagement with them. But still, their input is definitely worth it and worth the effort. But for now, I will hand over to my colleague, Christian.
Thank you for that, Søren. And touching upon Søren's presentation about the empathize phase, we moved to the next phase, which was the design phase, where we used all of our insights from the empathize to define the user's needs. So here we, for instance, created personas and user journeys to get a better understanding of who is the intended users of SAM and SAFE in the different countries, but also something about to identify cultural and linguistic differences. So for instance, here we could see that one term in the SAFE app was self-harmer, which was not intuitive for Dutch users. So this has to be changed for people who self-harm. But we could also see there was some technical infrastructure that varied a lot for the two apps. SAM was prepared for multiple languages, but SAFE required an adoption for the new market, to the Dutch market. And in the next phase, which was the ideate phase, we started to generate some idea to address these definitions we made. it could be seen as a minor phase, but it was very crucial to make this ideation, to see how could we ensure that there is an alignment in the content of the two apps in the cultural context. So here we used mind maps and brainstorms, but also we involved both clinicians and the intended users to see how can we adapt to the cultural differences. Here is one key that the adaptation of translation is very time consuming. We used both a professional translator here in Denmark, but we and in Holland we used AI translation. Both methods required early involvement of professional clinicians to validate and also proofread the content, so we could see if the terminology was good. But keep in mind that this is a very iterative process to get the translation correct from the start. And the next phase was to get some prototypes running, and this was also a preparation for the test phase. So one of the things we made were low fidelity prototypes, which could be just a piece of paper, and we created two versions in a low fidelity prototype of the content of the apps here in Denmark, where we tested SAM. And later on, we made some high fidelity prototypes, which was set up in Figma, so we could provide more deeper usability insights with both clinicians and also in the intended users. So keep in mind that prototype and testing is very iterative, so rapid prototyping will help identify the issues early on, and this was a lesson learned from us, that the iterative process is something that you have to keep in mind, but this also how should I say, meets user needs from the start. And then moving on to the test phase, where we gathered feedback from the users and refined the apps. So this became very useful, where we have the low fidelity prototypes and high fidelity prototypes in as a support, because this was more realistic for the participants to see the product in their hands. In relation to how we tested in the pilot test with SAM, we used a usability test where we had the participants close to us and we had the direct contact. And in SAFE, in the testing of that, we used surveys and clinician interviews, and we could see that a lesson learned is that the direct contact with the users provides more enriched insights and more enriched feedback from the users, even if it's a vulnerable target group. And Søren, if you will press the next button, then we can have some key considerations. Because when you are going to a new market, then you have to understand the cultural norms, the attitudes, but also the service gaps of the market, and how can you fulfill a gap with your digital intervention in a new country. And you can do so with collaborating, as we did here in the Super project, with local partners, mental health organizations that can navigate in the language, the culture, but also in the legal regulatives in a more effective way. And as Søren presented, the applied design thinking as a kind of mindset, this can give you a more enriched feedback and also refine it and ensure that your digital mental health solution is user-centered and can see a new insights of that. Mm-hmm.
Adding to what Christian has already mentioned, it's important to acknowledge that the translation and local adaptation requires thorough preparation, and coordinating cross-border collaborations also takes time and effort. So involving users and clinicians within this process is definitely worth the effort, as well as the potential in scaling digital mental health solutions across borders, better utilizing the many good existing solutions. Moreover, when engaging vulnerable populations, clarity is essential. Clearly define their role, their time commitment, and the impact of their input to foster trust and a meaningful engagement. And lastly, you should, of course, investigate and ensure compliance with local regulations, privacy laws, and potentially healthcare system integration to ensure sustainability for your solution. So, if you would like to explore our complete guideline, including checklists, very hard-learned do's and don'ts, and a methods library, it's freely available in multiple languages. You are also very welcome to reach out to us or ask your questions in today's panel discussion. So that was it from our side.
Thank you so much, Søren and Christian. I think I can speak for the audience when I say thank you so much for all of the panelists' generosity, both in terms of giving their time today to talk about the project they've been working on, but also in making these guidelines available. We're now going to be welcoming back all of our panelists to take forward a panel Q&A. I will invite you.
Oh, I'm too soon.
Hello. I'll invite you all to ask questions from the audience. So, I mean, I think if we got everybody, we're just waiting for Søren. Oh, there he is. Right. I just want to just touch upon something from the previous presentation, because in the empathize element of the presentation, you talked about the difficulty in accessing different groups. And I just wanted to ask a question about how did you overcome some of those recruitment challenges? Because I know that both from a health system perspective with hard to reach populations, but also from a development perspective, it's really important that you do overcome those challenges. So it'd be really interesting to hear your insights and your experience in that.
Well,
I can take that if that's okay. Well, I think in the Danish adaptation, we struggled the most in regards to this, as we did not have a direct contact within our organization with people with autism. So we spent a significant amount of time, several months, basically writing a lot of emails, making a lot of calls, utilizing our network to reach organizations that work with people with autism, the patient organizations, care homes, all the institutions, organizations surrounding this group of vulnerable people, to actually reach them. And from several months of efforts, we managed to user test the SAM app with 6 people, 6 individuals with autism. So it's a lot of work. We spent a lot of time doing this, but I think it's definitely worth the effort, because the feedback was very rich. It was from their lived experience, their perspective, to ensure that we made the local adaptations to the app in Denmark, so it would be more relevant and more fitting in a Danish context.
Yeah, and to add on that, Søren, we did so for the Dutch situation for the Safe app. And we thought we had it easy because I'm a psychiatrist working at a mental health organization. So I had direct access to the practitioners working with the people that self-harm. But it proven to be not such an easy road, because they were really protective of their clients and relatives. So we had access to the one target group, the clinicians, but at the end, they wouldn't allow us to have direct contact with clients and relatives. So we had to leave that with the clinicians to do the things we needed to do with clients and our end users with the clinicians. So this was really a hassle and a struggle. And if we have to do it over again, we do it the same way as Søren and Christian did in Denmark. So start over, find access to direct end users. Yeah.
Thank you. I think knowing our audience at these eMHIC webinars, the involvement of those with lived and living experience is so important to the overall success of these apps. I wanted to touch upon sort of this idea of clinician and user convergence in ideas of what makes a good app. And so, Yvette, I'm going to field this first question to you. So from a clinical perspective, what are the biggest gaps between what digital tools provide and what patients actually need, but also what they want, and whether there's a disconnect between what they need and what they want?
There's a big disconnection there. So I think if you are making an application for people with lived experience who want to use it in their own accord, you need to have to know what their challenges and needs are. And if you're a clinician, you make the assumption maybe that you know, but you don't know. So when developing the SAM app, I really learned that if we hadn't done it away from scratch with clients, with end users, we would have made a totally different, not applicable app for them. But so this is really, really, really important. I think it's the most important thing that you tailor it to the needs of the end users and use them all the way in the development and let their opinion be guiding. And of course, you have restrictions in terms of finances, legal restrictions. So you have to sometimes take into account, of course, that point of view. And if you develop an app that the practitioner needs to use because it's part of the electronic patient environment, then you have to be more also sensitive about what the clinician wants. So the apps I make are strictly for people to use on their own. But if you're making a digital mental health innovation which has to be used by the clinician giving it to the client, then I think you have to listen more also to the end user who is also the clinician and make a mix of those two needs.
Yeah, I mean, it's such a good point, and it comes back to some of the earlier discussions about user can mean different things to different people. So, you know, where you are potentially as a clinician prescribing, quote unquote, an app to support with a treatment plan, it may be more important that, you know, the clinician trusts it, but equally from an uptake perspective, it's still really important that the end user, in this case, it could be a patient or it could be an individual or a resident from a kind of an inpatient setting, that it reconciles those needs. Christian, from a user engagement perspective, where do clinicians, in your experience, where do clinicians and users most often diverge in expectations for digital mental health tools?
Well, that is quite a big question. I think, let me just think about it. Well, there can be something in how they approach the apps in this perspective, and yeah. Søren, do you have anything regarding to this question?
I can help you a little bit.
Yeah, of course.
Because with the SAM app, one of the first points of feedback from the clinicians was that they thought the app was too difficult for users to use.
Yeah.
They were too vulnerable.
Mm-hmm.
And that was really strange because it was an app totally co-created with people with autism, autistic people who were really severe, they had severe illness because they were in specialized mental health care. So this was, I think, not the case, but the clinicians thought, well, the SAM app is not something I'm going to give to my client because it's not good for them.
But also touching up on your last question, Fiona, you could see that when we tested the SAM app here in Denmark, they said that the questionnaire in the SAM app was too difficult for the people here in Denmark. They were too vulnerable to answer the questions. It was too difficult. So they mostly used, as Yvette said, that the approach of getting they are too vulnerable to answer the questions. And when we tested it, they were actually quite good, and they gave us very good feedback on how they could stress monitor their daily life.
Thank you to you both. So how do we ensure that we reconcile clinical rigor and usability so that these tools are trusted and widely adopted? Because I think it's fair to say that we have, I think that it's your point around that disconnect between what a clinician potentially thinks that an individual will use and engage, and then at the same time, and particularly if you think about a treatment plan and you recommend a digital health tool, you want that user to use it. And so there's something about that education piece for clinicians to give them the confidence that actually this is suitable for the end user, but also for it to resonate with the end user, and for us to not kind of steer into sort of paternalistic views on what will and won't work for an end user. Do you have any sort of comments and reflections on that?
Maybe, Sylvie, do you have, yeah.
Yeah, I was just going to ask whether I could say something, because I think an important thing or factor to take in mind here is what the goal of your application is. Is it an application or an intervention intended to help the clinician? Is it one to better the services, or is it intended as a self-help app for the users, for patients, for clients? And I think there are different ways to tackle implementation barriers depending on the goal of your application. I think if we look at it from, I'm a researcher, so from a research perspective, we know that self-help applications, adherence there kind of plummets way faster than, for example, in blended care. So that would be a good approach if you want your application, if it's an application intended to be used by your intended user, by patients, but also by clinicians. You need to have kind of a plan on how they can use it blended, so that a clinician has it adopted in their practice and how to do this. And then if you then look at it from a more broader picture, it starts with educating our clinicians on what is available, on what is possible, and how you could do that. So yes, you can work on smaller things, but it's actually a bigger issue. If you look at, for implementation, it starts with education and information for clinicians, and then they can address this with their patients and clients as well. And then it's kind of a process. I don't think there's like one way or one solution on how to do this, but from a bigger perspective, if I take the liberty to take the bigger perspective, I think that's where it needs to start. And then educating our clinicians, and even from the start as students, just getting technology more in the education, so that they're also more open to it, because that's also sometimes an issue. Something that they don't know is hard to use, and then they have certain ideas of how an application should be, and then they're focused on the looks of an application and not really how it might work or how they could use it. At least that's my experience, both from research and from our implementation projects outside from the super project.
If I just might add one thing to Sylvie's comments, it's that we know that the clinician is the single most important motivational factor for the patients to actually use the digital mental health solutions. So if we help educate and convince the clinicians that these are valid and good solutions, we also get them on our side to help promote that and convey that to the patients. Because if the clinicians is wary of the solution, then of course the patient will also be.
Yeah, and sometimes the clinicians has a different win with an app. So for the SAM app to engage the stakeholder clinicians, we say you get a lot better contact with your client if you know the stress patterns and activities, and you will have maybe a more joyful connection with them. So this is for them the trigger to say use the SAM app. Also that it reduces stress by 30% and double scoping skills. But the factor about time efficiency and the joy in the work was for them the factor that we needed to stress for them to use it. So you have to think from a different perspective from each stakeholder what the gain is or what the incentive is.
The benefits of the empathize
Yes.
section, right?
Yes.
Yeah. Exactly, Fiona, something that we have to empathize on. But the knowledge we had about implementation here in Center for Digital Psychiatry, we also used in the define phase, where we could see how can the SAM app be used as a clinician into supporting the vulnerable people in the municipal society. So also mapping out that journey of how can we implement it and how can we facilitate that they can use the app, and also as a talking tool that they, as you said, Yvette, talk about the stress level. Is it been better since last time?
So thank you, guys. I think that could have prompted much more discussion, but I am thrilled that we have some audience questions coming through. So I'm just going to turn, because this was these two questions I think are really important and was following the format of the panel anyway. So the first question is, what are the biggest challenges you faced in integrating user feedback into digital mental health solutions, and how did you overcome them?
That's a big question. Is somebody who wants to answer that, Søren, Christian, Sylvie, or shall I answer?
I think it might be interesting for you to share your experience with some, or even the SAFE app. If you got some feedback, how did you use it? Because I can imagine that, maybe adding on that question myself, what if there's some feedback that you didn't expect, or that is maybe hard to incorporate? How did you do that for SAM, or how did you do that for SAFE? I think that might be the question as well.
Yeah. Well, I can elaborate more than on SAM, but also on SAFE. So for the SAM app, we have a SAM panel, the SAM ambassadors, 300 people in the Netherlands who help us develop it further. So they have a lot of wishes, and sometimes those wishes don't approve with the like SAM is a stress pattern recognition device. So one of the big feedback we gain all the time is that they don't like the pattern in the questionnaires. But I cannot change that, because if I change that, I change the working mechanism. So this is something I explain to the users, why this isn't something we can change. But what we now did is we added a button that they can fill in a questionnaire whenever they want, added on the patterns where the questions already come. So we try to work around it that way, that they get what they want, but we still don't lose the working mechanism. Other things to challenges are, of course, financial challenges. So as well for SAFE as SAM, people would like to have a button and then a print or an email with their personalized data in an overview, which they can easily share with loved ones or people they want to share it with. But this is also something that costs a lot of money. We don't have that money. So this is something we cannot do. But then there are other things, like in the feedback from Denmark from the SAM app was that there needs to be more distinction in the buttons in the SAM app. Well, that was an easy fix. Not too much money, and technically fine to do, and also an improvement for the Netherlands. So this is something we did immediately. So it's and also, like in the SAFE app, it was compliant with the health environment in Denmark. But in the Netherlands, it's quite different. In Denmark, you have in every region a point to go to when you are in crisis with self-harm. For the Netherlands, that's not the case. You just have the general practitioner, and then the acute crisis psychiatry will come. So this had to be changed also. And that was is all the time a discussion with the people owning the app, and then telling them what you need. And then they need to understand that this is a good thing to do, or it won't work in another country. And then they need to know whether the money is there to make that change. So I don't know if I tell it, this finances are a challenge. You want to keep the working mechanism of the app, that's a challenge. And of course you have the legislation of the app, because the SAM app is not a medical device, but if we make it more like an intervention app, could be, but then you gain the risk that it will be a medical device, and then you have CE markings, and that kind of money we don't have at the SAM app. So that is also something for me to bear in mind, that I have to stay within these borders?
Mm. I think it poses some really, it is a big question because it poses some really interesting questions actually about the extent to which sort of digital health assessment frameworks demand and require this level of involvement, but you know how when we think about innovation and accelerators and funding, how they reward it, particularly where it might support attrition in usage of digital health apps. Which brings me to my next question, which is from the same member of the audience, and this feeds on some of the conversations we had last week. Again, user engagement in digital mental health apps tends to decline over time. We know that. We know that the vast majority of apps are abandoned after a relatively short period of time. What strategies have you found most effective in reducing attrition and keeping users actively engaged?
Well, maybe I can start with that, and maybe, yeah, for us, it's really good to keep on developing with them. So we build a community of autistic people, and this community helps us with the ongoing development of the app. So we have now big updates to add lived experience, to add exercise, and to keep on changing the content of the app. But on the other hand, I think for the SAM app, it's an app you can use 1 week, 2 weeks, 3 weeks, 4 weeks, then you can use it for a year, and don't use it, and then you use it again. So sometimes it's not the main goal to keep people engaged all the time. But if you want to keep them engaged all the time, you need to take into account that you offer new materials, new content, sometimes a reward system dependent on the public. So for people with autism, they don't like push-ups or sudden things in the app, but another audience might want to have that. A young audience, we know that because we investigated in researching young people. They would really like more like a gaming structure in it, a rewarding structure in it. So maybe Sylvie or Søren or Christian can add on that because you have a lot of experience with this also.
If I might add on that, I think this user participation that we are also advocating is critical in fostering this engagement also. And we could see from our user testing of the SAM app in Denmark that we would get emails and messages after our usability testing with the users, because they were now involved in the process. They were engaged in it. They could see that the suggestions that they came with were actually listened to. They were incorporated within the Danish version of the SAM app, and it made an impact. So actively engaging and involving users within the process and within this room, in the development room of the app or the digital solution, also in my mind fosters this engagement. Of course, adding to that with all the points you have made.
Sylvie, if you have from a research perspective, no. Christian?
I have nothing to add.
No, I have nothing to add either.
Okay. So I'm just going to turn to some more audience questions. So a 2024 review for Welcome of Ellie and digital mental health revealed that the vast majority of digital mental health research and development had no meaningful lived experience involvement. You have described a quite specific user-centered design approach. Can you talk about what principles and approaches are needed and implementation?
Sylvie?
Sorry, I was going through the question again because I'm not a practitioner. I'm a researcher. I read about this stuff, but I think it's more important to hear from you guys, if I may point or direct a question to you, because you are doing it. You have an application that you have implemented and are seeing how you can keep them, well, yeah, how to do that. I think what we did, maybe what I can say about the question or with relation to the question is that for the super project, we started from the experience of the Danish partner and the Dutch partner, because they had this experience with involving users, and they had like this positive, not really from a research background, but from just experiences of that things that work, but that indeed there's like a framework missing or doing it correctly. But then the Center for Digital Psychiatry, for example, but what I learned from them and how they work is that their design thinking approach is not really a framework that they adopt, but it's a way of thinking, a way of doing these things in their organization, and it's how they engage all their projects. I think I'm looking a bit at Christian and Søren, but it's not just a framework, a method that they're adopting, but it's really the mindset of their organization and how they work. And that is what is maybe not necessarily that framework, but or that mindset, but it's something that they had good experiences with and are using throughout their project, and that seems to be working. So that's something that we wanted to share. So I think it's important for organizations, for individuals wanting to do something with digital mental health, to kind of have also that mindset and incorporate it. And the thing with the design thinking is that what I've learned is different from what I expected and what I usually do as a researcher is that it's not one way or one strategy of doing things. It's really using all these different things. It's an iterative process. It's keeping on learning, and it's a mindset in how to do this. So I'm not sure whether that really answers the question, but I think that's an important lesson, at least for me, for the project, and how you can involve users with lived experience. It's not just using a method, but really starting from the mindset that it's important to have them involved in what you're doing and what you're creating.
Yeah, and it's really important to research when you make an application like the SAM app, that you do validation, scientific validation, and you do it in a quantitative matter and a qualitative matter. And if you have gained the data and you know what's effective and what's not, that you change your application according to the feedback you had from those investigations, together with your community and the feedback you get from the community. So it's like, it's not one thing, it's you do all these things together. And then you can have your application be engaging, validated, and being used, because you don't have to, the implementation part becomes really easy because your takers, your end users, they're so involved, they implement it themselves. So the effort you put in, the time you put in, it's a long wait and a late response, but it is worth the while, because in the end, the implementation will be really good. The compliance rate is really good if you do it like that. The compliance rate otherwise for digital innovations or apps or solutions is really, really low. I don't have the numbers, like 0.1% if it's not mental health, and I think 1 to 3% compliance if you're not you do user participation and co-creation with them.
I think it prompts a really, thank you, Ian, for asking the question. I think it prompts another, I think we could probably do a whole webinar on what constitutes meaningful lived experience involvement, and maybe that's something that we at eMHIC can take away. And I agree. I think that part of the things that we need to be thinking about is that actually this is not a static process, and this is an ongoing iterative process, and the extent to which that is factored in, both in terms of how the app is developed and how it continues to develop, but also in terms of how systems that are using these apps are supportive of that process and feeding back through, and thinking about how does that determine and influence their reimbursement strategies, their continued use of these apps, how they can support the developer, whoever that developer may be, to ensure that ongoing lived experience involvement, because it isn't a one-off exercise and a tick box. It's really fundamentally important that this is ongoing and iterative. I just want to come to, hello Nina, I just want to come to Nina's question because I think it's a really important question. And we had a similar discussion last week about, obviously, to non-Europeans, there probably isn't much of a difference between Denmark and the Netherlands, although I think that you have squashed that today. the process makes a lot of sense. Your example refers to a rather focused set of apps for specific populations in specific settings, but more and more apps are global. So, for example, AI chatbots. How do your guidelines take these globalization trends into account? I.e., if you try and, I'm going to build on Nina's question with my own question, but obviously, the broader the population becomes, do you run the risk of trying to be everything to everyone and in doing so being nothing to anyone? So I don't know who wants to take that question, but I do think that that globalization is a really important part to this, thinking particularly around the global south.
Yeah, I think I'll have a go at it. I think that's indeed a very important question, and a question that we also got during our our final event. Then, if you get all of this feedback and you keep on requesting feedback, aren't you making it too specific for all these groups, or don't you have to make then 10 different versions of your application just to suit everyone's needs? I think that's not, in my opinion, I don't think that's the way to go necessarily. But I do think, depending on the perspective you're developing from, I mean, are you a company wanting to kind of enlarge your market, create a new audience, and then it's better to adapt your application to kind of get more users. But from a more clinician perspective, because our background is more from the clinician perspective, I don't think we need to kind of reinvent the wheel every time. And if there are good applications in some countries or in some contexts, we don't necessarily need to have our application of our intervention available in each country. I think there it's important to take into account what the needs are for some populations. We don't need to kind of what's the word? We don't need 10 or hundreds of applications for the same things. We just need applications that work, or interventions that work. And if there are still no interventions that work or applications that work well enough, then I do think it's important to kind of involve those people with lived experience, or all different kinds of stakeholders, to do improve your intervention, your application. So it depends on what, I guess it depends on the perspective you take when looking at that question. Not sure whether it's a correct answer or the answer you were hoping for, but that's how I look at it. It really depends on the perspective of you take, because I think from an economic perspective, people will have a different idea than from a clinical perspective, I guess.
If I may add to that, I think it's in regards to the question. We have advocated for this local adaptation and localization of the solutions, because it's valuable. It's valuable that you can see yourself in the examples, in the content. And in our pilot testing and in our guidelines, we advocate for scaling and expanding existing solutions. So we have already been quite limited in what we have actually been able to change in the SAFE app and in the SAM app. Due to this restricted nature of an existing solution, we couldn't go in and say, oh, we want to redo the whole SAM app, because Danish users wanted this, of course. But we could go in and adapt and optimize the content quite easily without too many changes, actually, to the Danish context when we were adapting and translating the content, to make sure that it was culturally and locally relevant to a Danish context. So I still would argue that this is actually worth the effort to make this localization.
Yes, and I do think if you make it too generic, you have the risk of doing just nothing. That risk is there, because it has to appeal to people, and they have to feel that it's for them. And if you make it too generic, then it's for nobody.
Yes. I was so lost in the conversation that it's actually now 9:30. So we're going to have to wrap it up there, which is such a shame, because I think there is a really important conversation to be had around the extent to which these guidelines can feed into digital health assessment processes. And we know that there's obviously a lot of work going on in Europe, particularly around digital health assessment, but then also influencing work around the world as to what makes a good digital health app, and how does usability feed into that, both from a sort of a starting point, but also from an iterative development process. I just want to extend the biggest thank you to Yvette, Sylvie, Christian, and Soren for joining us today and telling us about their superb work with the Super project. Thank you so much. As always with these webinars, they prompt a lot of questions, they prompt a lot of debate, but that is absolutely what we're here for. Thank you very much to the audience for some really, really good questions. We will be making this webinar available via the Knowledge Bank for those unable to join us in real time. And we're very, very, very grateful for you to joining us wherever you are in the world. So as always, have a good day, evening, good night, wherever you are. And we look forward to seeing you next time. Thank you so much.
Thank you.